In this video, we're going to talk about defibrillation. Defibrillation is an intervention that is meant to stop any lethal cardiac rhythm that is present in a patient. The only two cardiac rhythms that you can defibrillate are pulseless ventricular tachycardia and ventricular fibrillation. The rest of the rhythms that might present with hemodynamic compromise and signs of shock might need to be cardioverted but not defibrillated. So there is a difference between the two interventions. A defibrillation is something that completely stops any abnormal rhythm in the heart. It renders the heart refractory, so the cardiac muscle cannot initiate any electrical activity for a few milliseconds, and then the hope is that the normal electrical focus in the heart will restart normal cardiac pacing. So we're hoping that the cardiac pacemaker after defibrillation will take over and start generating a normal cardiac rhythm. Now, cardioversion is a very different intervention that is not done for lethal rhythms. So it's not done for rhythms that are very life-threatening, such as ventricular fibrillation or pulseless VTAC. It's more done for atrial flutter, atrial fibrillation, ventricular tachycardias that present with a pulse. So those two are very different rhythms, and that's very important. Very different interventions, and that's very important to remember. So if we look at our monitor now, okay, our patient appears to be in ventricular fibrillation, which would obviously be an emergency, and in a real-life scenario, I would be moving a lot faster, but we're going to go through this step by step. So if I look at the monitor, I see that the rhythm is completely disorganized. I don't see any QRS complexes. The pattern is completely, there is no pattern to speak of. There are no T waves. So I know that my patient is in coarse ventricular fibrillation, and it's called coarse when my waves are fairly large. Fine ventricular fibrillation would look very, very thin, and we'll show you an example later. So immediately, I know what I need to do is I need to check for pulse, but I know that in ventricular fibrillation, the pulse in the patient is absent, and for sure the level of consciousness will be decreased, and the patient is most likely going to be unresponsive. What I need to make sure is whether or not the patient is breathing, most likely not, again, in ventricular fibrillation. So I will check for carotid pulse. I don't sense any pulse. Other points where you can check for pulse is obviously femoral or brachial. I do not sense a pulse. What I would do now, if I were alone and this happened, I would obviously push the code blue button. I would call for help. I would make sure that I'm not alone in this situation. While I'm getting help, what we're going to do is we're going to organize our patient to be ready for defibrillation, because I know that ventricular fibrillation is a rhythm that requires a rapid defibrillation within the first couple of minutes to improve the chances of our patient's survival. Recent studies show that the patient has good chances of survival if the defibrillation is done within the first 2-3 minutes, but you can go up to, well, you shouldn't, but you can go up to 5 minutes and the patients still recover with intact neurological function. So my job as a nurse now is to get this patient defibrillated as fast as I can. So what I'm going to do is I am going to ask for an EKG machine to be able to monitor the patient's heart. I am going to get my crash cart, which I already have here. If I don't have these, I will ask for it. I'm not going to leave my patient alone while I'm doing this. Obviously, I would have started, or I would have asked my patient assistant or another nurse to start CPR while I'm doing this. Okay, so when you see this on the monitor, your first step is call for help and CPR. While you're doing CPR, you are thinking of what else needs to be done for the patient. As soon as somebody else can take over the CPR from you, you start organizing your care for this patient, and that means getting your crash cart, your defibrillator, the EKG machine, making sure the patient has IV access because you might have to give different medication, and making sure that the doctor is in the room, and maybe calling an RT. So now I've exposed my patient's chest to get him ready for defibrillation. what I'm going to do next is I'm going to apply the defibrillation pads. My other option is to actually use the defibrillation paddles that are attached to my defibrillator. In most settings, well, in the emergency department, pads are frequently used, but paddles can be used as well. It really depends on how fast you need to defibrillate your patient. The pads might be faster. They unclip from the defibrillator by pulling up or pushing down this, and you need to unclip your both paddles, and you need to make sure that they're plugged into the defibrillator before you proceed. You have to remember that the paddle, the metal part of the paddle, does not go directly on the patient's chest. You need special gel pads or a gel that's applied to them. If you are going with the pads, let's look at our pads. Normally, the placement of the pads will be described in the front of the package. Of course, you have to make sure that the package is not outdated, it's not expired, but this is one of your safety checks that you do when you start your shift. This is not something that I'm going to do when my patient is in ventricular fibrillation. So I'll open the pads. On top of the pads, you will also see that the placement on the patient's chest will be very clearly described. In general, there are two types of placements. There is the anterior placement, where both pads are placed on the anterior of the patient's chest, and there is the anterior posterior placement, where one pad is placed on the anterior chest at the apex of the heart, and the other one is placed on the right at the scapular. So those are the two options. Both work well. There's no difference in terms of efficacy. It really depends on how your patient is doing and what kind of other devices your patient is attached to that will decide your placement. One thing to consider for anterior posterior placement is that you would actually have to roll or lift your patient to place that second pad on the patient's back. And that takes time, and you might need help to do that. So the faster method is the anterior placement. So if I open my pads, the pad that says front or anterior will usually go on the apex of the heart. As you remember, the heart's apex is about here under the left nipple, a little bit to the left, to the lateral axillary line. So I'm going to place it right here. When I'm placing it, I'm going to make sure that it adheres very well to the patient's skin, because if it doesn't, the electricity is not going to go into the thoracic space, into the thoracic cavity, and you might actually electrocute yourself, or the patient might get injured because the electricity travels on top of the patient's chest instead. If the patient has a lot of hair, which might happen, and the pads do not stick well, if this is a true emergency situation, such as a patient who has no pulse, who is unresponsive and needs immediate defibrillation, you can very briskly remove the pads, which will remove a lot of the hair, and reapply them. This should not be done for a patient who is conscious and whose hemodynamic status is not compromised, because as you can imagine, this is very unpleasant. In a situation that's less of an emergency situation, for example, when you're doing cardioversion, you can clip the patient's hair instead. Okay, so now I've applied the first pad on the apex of the heart. The second pad for anterior placement is going to go in the mid-clavicular line, like so. Okay, I've made sure it sticks well. Now, if you try to visualize how the electricity travels, you will see that it will travel between the two pads. If it's a biphasic defibrillator, it will travel one way and then the other way. And I can see, because I know where my anatomical position of the heart is, I can see that it will involve most of the myocardium, which is my goal. So you can always, when you're placing your pads, you can always think about how the electricity will travel, and you need to make sure that it involves most of the myocardium. Now for the anterior posterior placement, what I'm going to do, I would have to lift or turn my patient and place this pad under the right scapula. Okay, now different things that might happen. Your patient might be wet, because patients who are usually who are in a hemodynamic compromise might have the cold sweat on their skin. They might be wet for some other reason. So you need to make sure that their chest is very, very dry when you're applying the pads, because number one, the pads won't stick. Number two, electricity when you press discharge might travel on top of the patient's chest, because it would take the path of least resistance, which is the water. So the electricity will never get to the patient's myocardium. The patient may get injured and actually get an electrical burn, and you might get injured as well. Another consideration is to check whether or not your patient has any implantable devices, for example, an ICD or any kind of a cardiac pacemaker, because then you would need to make sure you have avoided those when you place the pads. Same goes for a portocath or anything else that may be present on the patient's chest. One more consideration is any kind of a transdermal patch. If the patient has one on their chest, you would need to remove it and wipe the area really clean, because if you apply a pad on top of it or a paddle on top of it, it will give your patient a chemical burn. Okay. So now that we've placed our pads on the patient, what we're going to do is we're going to connect the pads. Your defibrillator comes with a wire. This wire can be connected to paddles or can be connected to the pads. This connection, it might be a little bit tricky to get, so make sure you practice before you actually have to do it in an emergency situation. But in general, you will see that these two white little prongs go into the thin part of your connector. Okay, and there is a little thing that will click when you connect it properly, and that makes sure that this will not get pulled apart if you trip over something or if your crash cart has to be moved. So I've connected my patient. Now, while I'm doing this is a team effort. While I'm doing this, I will ask my helper or whoever is with me to apply EKG leads to my patient. And this is very important because we need to be able to monitor the patient's heart with an EKG. So ideally, I would have a 12-lead EKG, or at least the 3-lead EKG that comes available with your defibrillator. This becomes very important when you do cardioversion. For defibrillation, it's less of a concern, but I definitely want to make sure that I am capturing the patient's EKG.